we are going to go ahead and get started, and more people will, of course, be trickling in as they usually do. But welcome, everybody. My name is Corey Lubring, and I am the PBRN coordinator at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. First off, please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn their cameras on so we can be united as an OMM research community. Second, if you have any technical issues during the webinar, please put a message in the chat. Third, if you have any questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. We will also have time for discussion and questions at the end of the presentation. And lastly, keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. Today is our Let's Talk About OMM Research educational webinar entitled Osteopathic Considerations in the Treatment of Post-COVID Symptoms with Dr. William Devine. Dr. Devine comes from a family of osteopathic physicians, and after osteopathic medical school, he expanded his interest in manual medicine. He has interest in medical education, medical history, medical research, and medical health policy. He integrated osteopathic concepts and philosophy into his present osteopathic manipulative medicine practice. And he's nationally and internationally known and respected as a lecturer and author of topics in osteopathic manipulative medicine. His skills and interests were enhanced early from his experiences while serving within the United States Air Force as a physician at Luke Air Force Base, Arizona. And as an osteopathic family physician, his skills and interests expanded, including hospital committee chair positions, executive committee, and board member. Teaching residents and postgraduate education at hospitals and through the Arizona Academy of Osteopathy, the American Academy of Osteopathy, and the Arizona Osteopathic Medical Association. As president of the Arizona Academy of Osteopathy, he brought many programs to medical students, residents, and practicing physicians. He was a very active family practitioner for over 25 years, utilizing osteopathic principles and methods fully in his military and private practice. He was one of the founders of Midwestern University, Arizona College of Osteopathic Medicine, and served for 26 years. He has been honored with many awards over the years and his service to osteopathic medicine and teaching. Today, he is recognized by many medical organizations nationally and internationally in his medical specialty of osteopathic neuromusculoskeletal medicine and osteopathic manipulative medicine. He has co-authored 2 textbooks in clinical counterstrain osteopathic manipulation and has written and co-authored chapters in 5 medical textbooks and research papers. He is board certified in family medicine and OMT, as well as neuromuscular skeletal medicine and osteopathic manipulative medicine. He has a fellowship for the Osteopathic Research Center in Fort Worth, Texas, and his practice now is focused only on the field of osteopathic manipulative medicine and he actively continues to teach postgraduate medical education. So please help us in welcoming Dr. Devine.
Okay. Well, thank you very much. That's quite an introduction, so that's probably half my lecture right there. Greetings from Arizona, and it does actually snow. Right now, we're enjoying spring, which you have to understand it's about 3 or 4 days, and then it becomes hell. So I thought I'd let you know that osteopathic research is doing well in Arizona, and I'm going to share with you some ideas. You want me? I'm going to go ahead and share the screen right now and try to bring this up. Share and put this to full. Is this working well? Okay. We're okay. Is that enough? Okay, so right now I'm just doing a straight neuromusculoskeletal medicine practice. I've left teaching at the medical school I'm still working with postgraduate education at Midwestern University, ASCOM. And I've just taken up position at AT Still, Arizona campus in teaching the first and second year students. This presentation actually started with residents in treating cardiovascular problems such as congestive heart failure, pneumonia, and like that, using techniques known for years and years in our profession. There might be probably two things that may be new to you, but along came COVID. And of course, all of us have seen post-COVID syndrome patients now, and possibly the long COVID presentation has been of interest internationally as well. I've gone to Germany twice doing seminars involving long COVID. So I'm going to try to give some basic concepts of how you can treat long COVID with simple techniques that actually, although they're simple and may be regarded as shotgun techniques, they actually go back to early days in osteopathic medicine. They do a lot more addressing complications of viral and bacterial infections, and of course, the complication of the COVID virus. But simplifying it, I thought was necessary for residents and teaching clinical staff members, particularly if they want to do techniques for research. These techniques are just a suggestion. These techniques actually address the sympathetic nervous system, the neuroimmune system, the lymphatic circulation of the patient, the blood circulation, including microcirculation, respiratory function, which includes oxygenation of tissue, the parasympathetic system, which, as you know, has to be rebalanced to thin out secretions, and the neurolymphatic Chapman reflexes are also treated using indirect techniques, using the fascial components of the treatment I'm discussing. So these techniques hit the Chapman reflexes, hit the attempt to rebalance the parasympathetic nervous system, as well as the sympathetic nervous system with the neuroimmune, neurolymphatic, and other effects. The old DOs, there's some older than me, have, if you really think about it and you look back on their techniques that my father, who was a Kirksville graduate in 1933, who used these techniques as a DO surgeon, a urologist, on patients that had pneumonia after having chloroform or ether or other complications of surgery. A lot of DOs use these techniques, but with the cytokine storm and other coagulation problems from COVID, these techniques can affect this viral response from the dysregulation of multiple systems. So the techniques I'm talking about are one thing, but keep in mind we're osteopathic physicians. We really should look at the 5 models of osteopathy, and they should be considered along with the whole treatment plan and using clinical judgment on any technique, any procedure we try to do. So this will be brief. I'll mention our research at the end that we've done to date on long COVID, and some of the reasons for treating it. This is not an attempt to standardize the treatment, just a suggestion for some who don't have a lot of time. That'd be our residents and a lot of our DOs out there that only have 10 or 15-minute office visits. So let's start. So the first question that they asked me to put in, what has been learned so far in post-COVID syndrome or long COVID research? Well, first of all of you have probably endured the many papers that have been related to COVID-19. There have been some, including studies of long COVID, that have been out there, but there's so many papers, but virtually none on osteopathic manipulative treatment as a procedure to be treated part of the long COVID patients. The virus right now is on an evolutionary course, which is normal with all viruses, including influenza 1918. All of them drift in time. It actually could come back again in a severe form. But there are all kinds of variants out there now that are less severe as to damage. Still, we're having long COVID patients. As far as COVID is concerned, the moderate to severe symptoms really occurred in 1% to 5% of the patients. And actually, it's looking like it was less than a 1.1% mortality rate that's being disputed as far as COVID itself. But as far as long COVID, at least 65 million individuals around the world have long COVID right now. And a conservative estimate I got out of National Institute of Health said that 10% of infected people probably got long COVID, and more than 651 million documented cases of COVID-19. So anyway, 12 common symptoms. Many of you have seen them: that chronic fatigue, that shortness of breath. Of course, you'll have some come in and say, I have POTS syndrome from it, postural orthostatic tachycardia syndrome. A lingering cough, the so-called brain fog. It's called executive dysfunction in the coding book. Dizziness, paroxysmal atrial tachycardia from cardiomyopathy, sometimes heart failure, dysrhythmia, renal failures, all can be related to an exacerbation of other chronic diseases present on the patient, but it also hits young athletes too. The prevalence. COVID, of course, long COVID is an often debilitating illness for some of the patients. And once again, at least 10% of severe respiratory syndrome, coronavirus tube infections went into long COVID. More than 200 symptoms have been identified in the literature with impacts on multiple organ systems, clearly documented in the literature. 65 million, as I mentioned, worldwide are estimated to have it. The causes, well, there are, of course, hypotheses about what causes long COVID. It's thought that the initial COVID infection is triggered by an inflammatory cascade that produces the damage, which in turn causes lingering symptoms. And right now, the world basically is looking for biological indicators like antibodies immune markers or specific proteins in the blood that could be used to screen for long COVID. So actually having a blood test or a laboratory test to see if they have long COVID or some other clinical problem. Just because they had COVID, they may present with a problem some tied with COVID, and having a blood test would be very valuable to research and potentially monitoring the treatment of COVID patients and the recovery of a patient over time. So we're hoping to get laboratory markers. One of the problems that cause the damage from long COVID is they become hypercoagulable. So some of the young athletes that were injured from COVID had hypercoagulable problems. Some of them had organ damage from inflammation. And these are common problems with long COVID as the source of damage. And the old DOs were chasing inflammation. I'm sure still did, and the others that followed them. There's another thing that has come up on the research, and it's being investigated, is a possibility of viral persistence. Most patients clear the virus from their respiratory tract quite quickly. The majority of us have. But the virus is usually undetectable by PCR testing, or after a few weeks, which many of you remember, you had to be tested, and it went away, and then you could work again or whatever your situation was. However, it's theoretically possible that the virus has become dormant in some people, and it's in different areas of the body, and will reactivate to cause the long COVID symptoms. And we haven't seen evidence to support this theory on a research basis, but this is a theory that is out there. Another hypothesis is that COVID infection may reactivate other viruses, specifically Epstein-Barr virus, and the reactivation that leads, of course, to a long COVID symptom. Of course, the risk factors all of you have seen, and were many concerned about increased risk in females, diabetic, type 2 diabetics. Epstein-Barr reactivation has been documented. If they've had Epstein-Barr in the past, presence of specific antibodies as a result of COVID. They're actually identifying them now as a risk factor. Connective tissue disorders, such as rheumatoid, obesity, not being patients that weren't vaccinated is a risk factor. 1/3 have no pre-existing conditions, however, and so pre-existing conditions can be a risk, but 1/3 get it without pre-existing conditions. But if they've had a really severe infection, they have an increased risk of long COVID. This chart came from the National Review of Microbiology, giving symptoms versus pathology, chest pain, palpitations. Of course, that's the heart damage, with the myocardial inflammation and POTS. The lungs, cough, dyspnea symptom, but also abnormal gas exchange. The damage to the alveoli themselves from the cytokine was a significant problem. And it took a while for the cells to actually come back. The pancreas damaged, if they're diabetic, pancreas injury is a problem. The immune system itself is interesting. The autoimmunity is affected, those diseases. The MCAS, that's mastocytosis, occurs when your body produces too many mast cells. This phenomena was particularly noticed with COVID, and also possible cause of long COVID. And gastrointestinal tract problems, of course, the patients will have nausea, abdominal pain, loss of appetite. The microbiomes, the gut dysbiosis, the viral persistence and viral reservoir concepts are out there. And here's more of the chart talking about the cognitive impairment. That's your brain fog, the fatigue, disordered sleep, memory loss, tinnitus, and all of this has to do with the neuroinflammation and reduced cerebral blood flow. But I'm also saying cerebral lymphatic, it's called glymphatic circulation, and then small fiber neuropathy as a result of COVID. Kidneys were damaged, spleen and liver, and this organ injury with elevated enzymes and other elements of measurement have been clearly documented in the literature. I did mention, so you have patients with fatigue. Many of them have circulation deficits from the coagulopathy. Deep vein thrombosis occurred in some of them, but endothelial dysfunction, all kinds of showering of micro clots to the brain and other tissues, including major muscle groups, pulmonary embolus, and stroke. Also, having small strokes as a result of COVID, causing long COVID symptoms. Reproductive system itself in some patients were affected. All of you remember this guy. I first, actually, when I visited in Milan and did a presentation, I saw a picture of the guy on the right, and I took that home, and that was a picture of a physician during the plague. And of course, the one on the left is kind of blurry, but it's a print of the original discussion of what a physician of that time should be dressed in, addressing the plague. And I think the guy on the right, when he just tapped on with a wand on a patient, with gloves and the mask with the different herbs in the mask, including garlic to protect him, and the protective robe. At the time, I thought that was an example of managed care. But anyway, we wound up with COVID having to dress in a protective uniform. Is that necessary now with long COVID? Well, I would say it's up to you, but I don't worry. I've been vaccinated, and I did get Omicron for Christmas last year. I'm not taking precautions personally other than the usual hand washing precautions. If the patient has an active viral infection, I am concerned, however, but with long COVID, I see no reason to dress up like a doctor of the plague. So OMT is only an approach as part of a whole system as osteopathic physicians. And many of you are aware of the American Academy, and now in the schools, we're teaching the 5 osteopathic treatment models, which are biomechanical, which OMT clearly addresses, the respiratory circulatory model, which again, OMT clearly addresses, the metabolic and energetic model, like if they're a diabetic or have other problems, that actually a clinician will address those on a patient. The neurologic model is addressed by OMT, and the behavioral model, it's body, mind, and spirit to SDOs. I'd have to say that has to be addressed on your long COVID patients because their lifestyle has been altered. And this is part of the consideration on those patients if you're a DO. We really are trying to do a holistic approach and looking toward the patient's health and not just symptoms, which I mentioned. So let's talk about these techniques, which I distilled down for residents and busy clinicians. And once again, these are only suggestions. I think it'd be better if you saw me or some of the physicians I've trained do them in person in a small class. But here they are. And I use these before COVID and certainly for residents for long COVID instruction in our GME system, and certainly taught our ASCOM students. But these techniques have been used on post-ventilator patients, which I treated in the hospital. The first rule on this technique is start at the thoracic outlet, and it has to be freed up. The thoracic outlet and inlet both should be freed up. This isn't just a mechanical measure. This, of course, mechanically opens up the lymphatic circulation, but also address the parasympathetic and sympathetic nervous system at the cervical thoracic junction. It directly addresses this neurolymphatic reflex, but also flow, so reflex as well. It addresses the neuroimmune reflex. It restores extrinsic and accessory respiratory muscle excursion and function. It addresses it through, in this case, the mechanoreceptors in the fascia, as well as restoring musculoskeletal balance of the segment. And it's one technique. And the technique improves the microcirculation of blood, lymphatic circulation to the body below the neck and thoracic outlet, but also to the brain, the glymphatic circulation. It helps it. It's one of the techniques that we're using. Once again, I have 30-minute office visits, so I had other techniques, of course, I would use, but this is basic for the busy practitioner. So you all remember the so-called necklace technique. But this, what is new about this technique, you engage the patient just like you did with the necklace technique. You engage that thoracic outlet, putting your index finger to the first ribs with your thumbs on the transverse process of T1, and check back and forth till you find an indirect position, a position of ease in the thoracic outlet. You hold the patient in the position of ease, and then you bring up to the position of ease and have the patient turn toward the barrier. This is a reciprocal inhibition muscle energy technique, but I'll talk about it later. It actually is a modification of one of Still's technique that he used on the diaphragm. So engage the thoracic outlet, put the patient in direct position, and then have the patient, like on the extreme view on the right, move toward the barrier. While you resist it, you hold it. And so you go back and forth. And probably 3 to 4 times, the thoracic outlet, believe it or not, is opened up, as opposed to using the indirect or direct myofascial release technique, which may take a minute or two to do. You don't have a minute or two. So then, of course, you recheck. Anyway, this helps restore that first rib motion, affecting lymphatic flow to the brain, the lymphatic flow. Right and left thoracic ducts it helps open them up, and it treats the sympathetic and parasympathetic ganglia in that region, which is really important for ENT as well as pulmonary and cardiac response. The next one is direct myofascial release of the cervical sympathetic chain ganglia. There are three major chain ganglia in the cervical spine. The so-called dural tube, so this is a cranial technique as well as the anterior and posterior lymphatic circulation. And eventually, when you get to the atlanto-occipital region, the suboccipital area, you're treating the vagus, your parasympathetic. And this technique goes way back to the early, to 1900 era. You start at C1, at C7, T1 region, and just start doing the stretch and work toward the atlanto-occipital junction. So here you're working up, you're hitting the posterior and anterior lymphatic circulation, as well as at the same time you're hitting sympathetic chain ganglia with this technique. And this is important. It's not just a feel-good technique. It has to do with immune response as well as circulation. So here's a familiar technique to many of you, and of course they used it on tonsillitis in the past, but this direct myofascial release, holding on, I hold onto the sphenoid. You can see with my right hand in this technique, the left hand going back and forth, doing a bowstring type technique. I'm hitting, again, the cervical sympathetic chain ganglia, anterior and posterior lymphatic circulation, helping the WNT, but also you're hitting the Chapman reflexes, which to the heart and lung and sinuses and brain, the lymphatic and microcirculation system, but also the vagus, which is important on your patients with POTS. You all have seen, of course, the so-called suboccipital inhibitory release technique, and probably some of you used it on your classmates' hangovers when you were in medical school. But what this really is a basic cranial technique, and it really hits the vagus, the parasympathetic vagus, but also that region is loaded with vital Chapman reflexes. So here is another clinician doing the suboccipital tension release. Once again, this is a vital thing on your brain fog patients. Here's a direct myofascial release. This came from Dr. Ward in his discussions of direct and indirect myofascial release, and you're using intention in the system, directing traction to the upper thoracic region, particularly T1, T2, T3, T4, for your cardiopulmonary effect on the patient. So you're actually having intention into the upper thoracic spine, as well as opening up in this case, this picture shows the right shoulder girdle. Under that right clavicle is the right lymphatic duct system. which drains the lymphatic circulation of the heart and affects all of the lobes of the lung except for the left upper lung. Just that one myofascial release technique. I use this in the intensive care unit. So you're hitting rib cage function, restoring excursion of the ribs. You're hitting lymphatic circulation, but also neuroimmune enhancement with the Chapman reflexes that are on the anterior posterior upper thoracic spine. So you're not rubbing the Chapman reflexes, you're indirectly affecting them through fascia. So now this technique is an old one. This is an oscillatory technique or shoulder shake technique to the shoulder girdles, is described by Littlejohn. Shoulder girdles, both sides are opened up after you've done this direct myofascial release of both shoulders. These two techniques just take several minutes totally to do. It's just, and you'll feel the release, but you're opening up the lymphatic circulation to the lungs, the cardiopulmonary circulation, as well as restoring rib function. So I mentioned things are not particularly new here. Here's 1898. Here, this is the first edition of AP Davis, MD, of Kirksville. It's taken at Kirksville. And he's doing, it's entitled Back and Shoulder Treatment. He actually has his finger pads in the deep multifidus muscle groups affecting the sympathetic ganglia, which are right next to the transverse processes. So he's hitting all of the posterior sympathetic ganglia. You'd say, well, he's just opening up the shoulder movement. Well, that certainly would help a patient too. But getting the sympathetic ganglia is so important on cardiopulmonary patients. And this is I will tell you, when you find the long COVID patients, they will have a lot of tenderness in the in the T1 through T5 region. You're all familiar with rib raising. This comes from illustrations by Dr. Shaw and Dr. Dyer from their textbook. Patients supine and they just doing rib raising with the finger pads. Well, in a hospital bed, it's not that easy to do. But anyway, this technique is effective, and it actually restores motion of the ribs. And it's thought to be a lymphatic technique, but actually, again, those finger pads are properly done are in the sympathetic ganglia, which is right next to the spine, which are totally important on your long COVID patients. The next one that's familiar to you is that anterior chest wall sternal lymphatic pump. And the patient supine, put both hands together on the sternum, anterior chest wall. And of course, that's where Simpson's fascia is. And the patient inhales fully, and on exhalation, applying a gentle posterior caudate pressure. Some clinicians may use a vibratory or oscillatory technique with this as well. And there's a momentary resistance sometimes, and the patient takes a deep breath and they let it go. You use your clinical judgment on this technique, but it certainly has been used. If they're an active patient COVID, it may actually spread viral particles. So, but certainly in early stage or on long COVIDs, it would be, I would recommend it. I certainly used it this week on one of my long COVID patients. But if they're in acute respiratory distress, use it with caution. So something I would add as far as caution, here I'm having the female patient put her hands on sensitive parts, where her breasts, when you're doing the technique. I suggest this whether you're a male or female operator. But this anterior chest wall pump is effective. Understand that under the sternum is the greatest concentration of lymph glands in the body. So you're hitting heart and lung lymphatic circulation. Remember that abdominal diaphragm release you hated as a student, where you're reaching over and gouging under the rib cage. And of course, as you learn to do it, it's not so painful. Here's again, Dr. Davis doing it on a patient, and he's leaning over the patient. I don't know if it's for the photograph or if that's what he did. But actually, Dr. Gashall, who's did some research on Still's work, found that this was Still's technique for releasing the diaphragm. So the patient would take a deep breath and then let it out, and he would compress laterally, both hands, bring him toward the midline, following it in, and then have the patient take a deep breath against resistance, in and out. And actually, we used it on patients who came off the ventilator where the diaphragm was really weakened. And I've used this on all of my long COVID patients rather than gouging under the rib cage and taking time. So this is an AT still combined muscle energy. It's actually a muscle energy technique with respiratory assist to release the diaphragm. And actually, in most patients, it took only 3 or 4 excursions, and you can feel both diaphragms balanced in 3 or 4 times. This was an amazing technique to me. So here we're back to Little John. And when I was in England, Christian Fossum showed me this technique. Little John iliopsoas subdiaphragmatic pump. This is what I'm calling it, an oscillatory technique. So you actually take the leg and with intention do direct vibratory forces or oscillatory forces to under the diaphragm. That's where the cisterna chyli is, but also picks up the inguinal nodes. The pelvic diaphragm are released. The lower extremity circulation of blood and lymphatics. I might add that the popliteal diaphragm also is treated on your patients that have risk of blood clot. Pedal pump, you remember this, doing plantar flexion, but you also should do the dorsiflexion as well on this oscillatory wave that you create. So this is again is an oscillatory technique, and that's it. And if you do that, you're treating all of those symptoms, and it a lot faster than what I explained it. But keep in mind the sequence of treatment's important. Always start at the thoracic outlet, then go to the cervical spine, doing that myofascial release. You open up both shoulder girdles, hit that respiratory diaphragm, do the rib raising, chest pump, and then go to the dorsopedal pump eventually. That lower extremity release technique with the oscillatory technique should not be done if you even think they have a blood clot, of course. Treat the greatest areas of restriction first before you do this technique if you have time. But these 11 steps have worked very well. Once again, you're hitting the vagus, you're hitting sympathetic ganglia, and you're relieving pain, nociceptive access. And you're helping the brain circulation for your brain, the lymphatic circulation. Brainstem itself is treated not as well as some texts we do. Now, I want everyone to know that you can be paid for doing OMT if you haven't learned by now. It's well worth your time. I mean, you can charge for 9 to 10 regions of the body, 9, 8, 9 to 9 with this technique. Of course, you should use a 25 modifier and proper documentation, but it could be a limited office visit, 99214, with the value of services, should bring a substantial value of services to you on billing. There are codes which are on the screen for hospital coding as well. But the diagnostic code for long COVID now is this U09.9, and that's been effective since October 1st of 23. But you should also, on your diagnostic codes, include what's wrong with the patient, like chronic respiratory failure, here's a code for it, loss of smell, sense of smell, the code for that, loss of taste, multi-system inflammatory syndrome may still be present, pulmonary embolus, the code should be after having a pulmonary embolus. Pulmonary fibrosis may be present, but that brain fog code, here it is, R41.9, memory loss, ICD-10 is F06.7, and then you include the 9 to 10 somatic dysfunction codes by regions treated, such as cranium, cervical, thoracic, upper extremities, ribs, abdomen, lumbar, sacrum, pelvis, and lower extremity, which all of these techniques address. And you can address all of these in 9 minutes. So with Touch.NET, we've only been able to get just a limited number of clinicians to sign up for caring for, we're only asking maybe 5 or 6 patients if you can do it. And we recommend that you sign up if you can for our study and you contact DO-Touch.NET. If you're still seeing patients with long COVID, in my practice, which is quite limited, I've been successful. I have none of my long COVID patients are having problems. They're back to their usual chronic musculoskeletal problems. First report on long COVID, which led us to the the study, was the number of severe mild symptom cases that came out of China early on, and the persisting symptoms in 50% of the cases at that time. And we thought, well, we could do a long COVID study using OMT. And so research, now what we're doing is, how does manual medicine or treatment as performed by osteopathic clinicians impact people suffering with lingering symptoms after being infected by SARS-CoV-2 virus? That's what our study is, and it's any type of manipulation and osteopathic care you give the patient. It doesn't have to be what I just described to you, which is quite simple. It's a timely opportunity for our profession to test the osteopathic hypothesis that OMT can impact more than just the musculoskeletal system. And of course, we know that from the Spanish flu.
Dr. Devine, I just want to let you know that we will have to wrap up soon, so we can have a little time for discussion. So.
Okay, and so here's the study that I presented at the Osteopathic Congress in Berlin, International Conference in June of 23. It came in second in international competition, even though I clearly said that that it has not been at this poster says we have not completed the study. And when they invited me back again in November, hopefully to present the completed study. So I'm open to suggestions or whatever, but that's about all I have time to say. And here's some references. And so sorry for taking so long, but there was a big subject. We're all interested in it, and we want to put osteopathy into long COVID study.
Thank you very much, Dr. Devine. And there's no need for apologies or anything. Like you said, it is a very extensive and hot topic these days. We just want to have a couple minutes that we could have people that are attending just open up a couple questions and discussion and everything. So if you could stop sharing your screen when you have that stop share button there. Thank you. We did have a couple questions in the chat that we wanted to address first. And if we have time, we'll also open up for any other questions. But we had a question from Jed Downs that asked, is there any evidence of the virus being incorporated into the genome via a reverse transcription DNA?
Yeah, I'm sure there is. Actually, my wife is a clinical pathologist, a DO, and we were discussing some papers that we've run across lately, but I'm sure there is, but I can't name the study at this time. But I actually, as much money has been put into it, I think that we're probably going to see some information on that come out. Yes, sorry.
Well, thank you. And then we had a question from Dr. Marie Jackson that asked, is there any evidence that certain blood types are more susceptible to COVID or long COVID?
It was once thought to be that, and from what I've read, and some of you have read on the research on that, I'm not with the way they collected their data, I'm not sure that that's the case. But there are some blood types, of course, and some differences in immunity on different peoples with different blood types. So I would say maybe.
And we have time for maybe one more question. If anybody here has a question that they would like to ask. And you can feel free to, if you want to just speak it, you can unmute yourself and just speak instead of typing into the chat. Yes, Dr. Downs.
Yeah, my approach has been to be more direct with regards to the interface between the lung and the chest wall, or the lung and the pericardium, or the diaphragm and the liver, in terms of really working locally on the kind of serosal restrictions that I find. I'm wondering if anybody else falls into that camp, or if these more general techniques are adequate, because I really feel like sometimes it's relatively difficult. It takes a fair amount of vibration and stuff to get things to really free up. I'll go offline, let everybody else.
Yeah, I totally agree. As I continued on with the long COVID care on patients, one could only walk 10 feet without sitting down on chair with a stool attached to it, and I've had to focus in on her heart damage, and of course all the patients had a cardiology consultation, so I could actually individualize for different organs using somatic visceral reflex treatments.
And then Dr. Robbins, you have a question? We'll do this as our last one.
Thank you. I posted in terms of insurers and multiple sessions that are complex, comprehensive, and complete 9-10 sessions. My secondary question from Dr. Downs's intro is, what about the fibrogenic and the more systemic effects of soft tissue treatment and the total body fascial component?
Well, yeah, of course, in your case and mine, we're going to use other techniques than the simple techniques we're doing. But I'd have to say, if that's what your question is, would these 11 steps address some of the problems that we know is out there? And the answer is, it's to use the term, it's good enough for government work, but for you and I mean, I'm sure your visits, like mine, are at least 30 minutes on these patients.
Thank you for a wonderful presentation.
Yes, very much. Thank you, Dr. Devine. And unfortunately, our live discussion time is up. So don't forget that this webinar recording will be placed on the DO-Touch YouTube channel, and we can continue any discussion, and watch your email for an announcement for when that recording is available. And just a reminder, our next episode of Let's Talk About OMM Research will be a journal club on Thursday, May 16th with Mr. Julian Moreno, and the topic will be the role of mental imagery in osteopathic palpitation. And until then, we will see you all next time. Have a wonderful day, everybody.
Thank you very much. Have a good evening. Bye-bye.
Thank you. Bye.